Hi, everyone. Welcome. We are so excited to have you joining us today. Extended genotyping for HPV positive, clear, convenient, guideline supported. Some of the learning objectives for today, we're going to be exploring the latest in HPV screening guidelines, discussing how extended genotyping can give you more clinical insights and how to easily interpret extended genotyping results using the ASCCP app. We'll highlight the option of guideline-supported self-collection, including its potential to expand access to HPV screening along with practical considerations for clinical workflow. We will hear from our speaker, Kylie Johnson, on how these innovations are reshaping screening and management strategies to bring value to clinical decision-making and patient care. Kylie Johnson is a dual board-certified nurse midwife, a women's health nurse practitioner, and the founder of Rocky Mountain Wellness Clinic in Idaho Falls. She earned her Bachelor's of Science in Nursing from Idaho State University and completed Georgetown University's prestigious dual nurse midwifery and women's health nurse practitioner program. Kylie's accomplishments have been driven by her desire to pioneer new possibilities for women's healthcare while remaining deeply connected to her community. She leads with a commitment to empowering women through education, choice, and holistic patient-centered care. Before we pass to Kylie, I just wanted to kick things off with some quick background information that highlights the critical need for cervical cancer screening innovations. Cervical cancer is the fourth most common cancer among women worldwide. In the past year in the U.S., close to 14,000 new cases of cervical cancer and over 4,000 deaths have been reported. And this devastation is preventable. Approximately 60% of invasive cervical cancers in the U.S. occur in the under or never screened population, which we see often in underserved communities. Disparities in screening occur across race, socioeconomic status, and sexual orientation. And these known barriers to screening are why innovative approaches to reach that 60% is so key. With the advent of organized screening programs like the Pap test, incidence of cervical cancer has decreased by more than half between 1975 and 2007. However, since 2007, we've since seen a plateau in incidence rates with clinician-collected specimens and co-testing with limited or no HPV genotyping. This plateau isn't the case for all women, though, because we've actually seen a 4.4% annual increase in distant stage cancers in low-income women and a 1.7% annual increase in cervical cancer incidence in women aged 30 to 44. And based on large modeling studies, we know that incidence rates will decline more rapidly by increasing screening rates than by increasing vaccination rates, which is still an important part of the puzzle. Circling back to the reason for innovation, cervical cancer screening rates have plateaued with cytology and co-testing. And so it's the combination of extended genotyping and increased options for testing like self-collection that can really help us reach cervical cancer elimination. And with that, I will pass it over to Kylie, our speaker for today.
Thank you, Stephanie. I am so honored to be here today talking about something that I'm extremely passionate about. And my hope is that all of you leave today inspired to level up your practice and offer patients the most innovative care possible. So to start, I want to reiterate that the data that Stephanie has shared thus far is incredibly important because it highlights the limitations of how we've traditionally approached cervical cancer screening, and it sets the stage for why the innovations we're discussing today actually matter in practice. So just to level set, I want to start by briefly grounding us in a couple key concepts that I think often get lost in the weeds when we discuss the fine details of cervical cancer screening. First and foremost, HPV is responsible for the majority of cervical cancer and precancer. And second, the entire goal of screening is to detect precancer before it progresses into cancer. So with those foundational concepts in mind, let's dive in. At this point, many of you are hopefully familiar with the updated ASCCP guidelines, which are truly foundational to how we deliver evidence-based cervical cancer screening today. These guidelines are designed to optimize outcomes by improving detection in higher risk patients while simultaneously reducing unnecessary procedures in our lower risk individuals. And importantly, they continue to evolve alongside advancements in technology, with the most recent updates published in June of 2025. So some of these key updates include a shift towards risk-based management, integration of extended genotyping, recognition of primary HPV testing as a screening method, and most importantly, the addition of self-collection as an FDA-approved option. These newly updated guidelines have separated HPV genotypes and associated risk into nicely organized tiers, which then provide clear insight into clinical management recommendations for us as clinicians. Results falling into Tier 1 with types 16 and 18 identified are at the top with the highest risk of progression associated. These results warrant immediate referral for colposcopy. The genotypes that fall into Tier 2, the moderate risk category, come with a recommendation for triage with the purpose of further stratifying risk to determine our next steps. So triage in this case can be done with dual stain or with cytology. And then Tier 3, the lower risk tier at the bottom, which is actually a new practice change, simply recommends repeat screening in 1 year for surveillance. At the very bottom, you can see the recommendation for negative results, which triggers repeat testing in 5 years if the sample is a clinician-collected sample, or 3 years if done with self-collection. I love this approach personally. Being able to see these clearly delineated tiers with the associated risk eliminates the confusion or inconsistency in both triage and management that I think we saw with the previous guidelines. So because of this new practice change, we have seen a reduction in unnecessary procedures that have previously burdened our healthcare system and potentially even compromised patient outcomes. Historically, we have relied on screening with either cytology alone, HPV co-testing, or HPV testing with partial genotyping. And as Stephanie mentioned earlier in her intro, while those approaches have served us in the past, they are no longer moving the needle in reducing cervical cancer rates. Without the power of extended genotyping, those beautifully organized buckets of risk would just not be possible. So let's break this down a little bit for further clarity. Most of us are used to seeing type 16 and 18 called out, and then everything else is grouped into a pooled high-risk category. The On Clarity test provides callouts for 6 individual high-risk HPV types, type 16, 18, 45, 31, 52, and 51, and then 3 strategically pooled groups based on HPV types with similar risk. This really matters because now we know that not all high-risk HPV types behave the same. So when we rely on pooled results, we can unintentionally overestimate or arguably worse, underestimate a patient's true risk, which in turn impacts how we manage them long-term. A side note here that I want to mention is that no other FDA-approved assay on the market provides the level of detail that On Clarity offers. And the cherry on top is that it now perfectly aligns with these ASCCP risk management guidelines. So to complement all of this new insight, the ASCCP app is officially updated, which is a total game changer for all of us and how we get to apply these guidelines in practice. What's important here is that the app now reflects that tier-based, risk-driven approach that we just discussed, and it specifically calls out On Clarity as the only HPV test that provides the extended genotyping capabilities. So if you're currently using the app, just make sure that it's updated so that it can reflect these new guidelines, and that's where you'll really see these changes come to life. Honestly, for me, prior to this update, it was difficult to confidently triage patients accurately, and it felt like so many of my patients got stuck in that dreaded colposcopy loop because we just did not have enough granularity built into these decision-making tools. But now we can input those results directly and make decisions that reflect a patient's true risk. This approach ultimately helps us avoid unnecessary procedures, reduce loss to follow-up, and feel more confident when choosing surveillance for our truly lower risk patients. And that brings us to why extended genotyping is so clinically valuable. So first and foremost, it gives us additional risk stratification beyond a pooled high-risk HPV result. So instead of treating all high-risk positives the same, we now have more detail to help us understand which patients may warrant closer attention and those who do not. Second, it allows us to track HPV persistence beyond HPV type 16 and 18. Persistence, as we know, is one of the strongest predictors of progression. So having that visibility across additional high-risk types gives us much more meaningful longitudinal picture. And then third, it provides clinically relevant results beyond type 16 and 18, which is becoming increasingly important as vaccination continues to shift the genotype prevalence in our population. So the overarching theme here is more precision in our results equals better decision-making and better patient outcomes. One of the biggest strengths of OnClarity as an HPV assay is its versatility. It can fit into your practice in whatever way works best for you. So it has been approved across the full spectrum of screening approaches, and it can be used with co-testing, reflex testing with cytology, primary HPV screening, and most importantly, and most recently, self-collection. This is where I get very direct with both all of my colleagues and my patients when I say that there is simply just no longer an excuse to not get screened, because we now have multiple pathways to be able to meet patients where they are at. So earlier, Stephanie talked about how the landscape of cervical cancer screening has evolved, and she identified two major barriers preventing us from eliminating cervical cancer altogether. That first major barrier is something that we've already discussed, which is limited genotyping. With extended genotyping, we now have a solution to that barrier. The second barrier is just as critical, and that's access to screening. Because no matter how good our tools are, they only work if our patients actually get access to them and actually get screened. And the reality here is that many patients still avoid screening for a variety of reasons. These barriers lead to real disparities in care. Until we address them directly, we are not going to win the fight against cervical cancer. While clinical screening guidelines have already expressed that HPV primary is a preferred cervical cancer screening method, as recently as December 2025 and January 2026, some major clinical practice guidelines have been updated, and they include support for self-collected samples as an option for HPV screening. So that includes support from American Cancer Society, Health Resources and Services Administration, otherwise known as HRSA, and ACOG, the American College of Obstetrics and Gynecology. And then shedding light on the barriers to care that we continue to face and the overwhelming support in the recently updated guidelines brings us the self-collection screening option directly into the spotlight. This self-collection method was designed specifically to reach our under-screened or never screened patients by eliminating the need for a pelvic exam. It is a direct-to-consumer option, but it is not an over-the-counter option. So a clinician order is required to ensure proper follow-up and surveillance. But really the important piece here is that it provides a solution that addresses the inequities and disparities that exist in screening still today. The number one question that I get about self-collection is it an accurate screening method? And the answer is yes. So data shows that self-collected samples tested with the OnClarity HPV assay show similar clinical accuracy to clinician-collected samples. That is critical because self-collection only adds value if it preserves confidence in performance. The workflow for this assay was optimized first for in-clinic use, then it was adapted for home use. So for the in-clinic workflow after collection, the sample is transported dry in a protective sheath rather than diluted in liquid-based cytology media. This allows nearly the entire specimen to reach the lab. It is then resuspended in an HPV lytic buffer intended specifically for molecular HPV testing, making this workflow built for molecular analysis rather than cytology. So from a practical standpoint, that exact workflow is consistent with how we already handle other vaginal molecular samples, such as STI or vaginitis testing. And this assay has demonstrated stability for up to 30 days at normal temperatures, plus tolerance for excursion temperatures. So the workflow offers flexibility for transport and expanded access. Overall, the message here is that self-collection can be both practical and clinically reliable, and it helps solve that issue that we have identified with enabling screening for underserved or hard-to-reach populations. So let's take a moment to look at how this all fits into the clinical setting. And here's how I would walk a patient through screening in my clinic using the OnClarity assay. So no matter which screening pathway I choose, it always starts the same way, and that's with patient counseling. I always start by discussing the importance of screening, why we screen, and then we review options available to the patient so that we can then align the approach with both the clinical scenario and the patient's comfort level. Then from there, we will select the appropriate pathway for screening. So for self-collection, you simply just instruct the patient to use the swab to collect a vaginal sample. And the patient is going to do this by inserting the swab vaginally up to this red indicator line and then swirl vaginally for 10 to 30 seconds. They then will just replace the swab into the dry transport sheath, and it's then sent to the lab for processing. And then alternatively, for clinician collected samples, we collect an endocervical sample as usual with whichever method you prefer, and then transfer that sample into the liquid-based cytology container. So the main difference here is that OnClarity needs to be selected in your EMR as your preferred HPV assay, and the specimen is transported to the lab for processing as usual from there. So with clinician collection, the critical part is to make sure you are ordering the correct assay to be able to get those extended genotyping results. And then regardless of the pathway chosen for screening, I can reiterate that this process is simple and the process is accurate. What I've personally seen in my practice is that self-collection removes a huge barrier across the board, where patients are feeling more comfortable, they feel more in control, they're more willing to actually complete the screening. That's been the most profound impact that I've noticed. It really eliminates a lot of the hesitation and resistance really that we see around screening, and patients do it and then they feel empowered. They leave knowing that they've taken care of something important that they otherwise maybe would not have prioritized. So it's truly a win-win for both of us. So now that you have an understanding of what the collection process and workflow looks like, I want to shift our focus a little bit to how to actually use the testing information that you receive. With partial genotyping, we're typically given results on HPV 16 and 18, and then everything else gets grouped into a pooled high-risk category. So while we know the patient is positive, with this type of report and test, we don't have the level of detail needed to fully understand their individual risk, and our decision-making becomes less precise. With the OnClarity assay, this report gives you the exact detail needed to make decisions compared to what we were getting with partial genotyping. So you can just simply take the results from this report, head to the ASCCP app, fill in the patient's pertinent data along with their history, plug these detailed results in, and then it's going to spit out that risk-based management recommendation. I've found that using the updated guidelines, which include the use of OnClarity, makes this truly a seamless process. So when we bring all this together, this is what it looks like in real life practice. From a clinical standpoint, one of the greatest values of OnClarity is that it helps us make clearer, guideline-driven triage decisions. Extended genotyping gives us more precision in separating who needs immediate colposcopy from who can safely return for surveillance without reflexively escalating every patient to more testing. It also helps with unnecessary procedures in lower risk patients. When we recognize that all HPV types behave differently, we can better align management to true risk. And that means less overtreatment, less patient anxiety, and more confidence in how we guide follow-up. The other major value here is that this changes how we follow patients over time. So genotype-specific information helps us move from guesswork to more intentional persistence tracking, which then changes how we counsel patients and how we think about risk longitudinally. But for me, one of the most profound impacts is what this means for patients who might otherwise avoid screening altogether. So I want to just quickly share an experience that I had a few years ago while I was attending the ASCCP conference. I had the opportunity to connect with a woman, a patient, who was there advocating for self-collection as part of the new enduring guidelines. She was a cervical cancer survivor herself, and she shared with me that her road to cervical cancer started with an extensive history of sexual abuse, which ultimately ended in losing her reproductive potential at a very young age. So for her, gynecologic care was never just routine care. It carried fear, it carried vulnerability, and it carried the risk of being re-traumatized. She talked to me about how these factors were leading to avoidance of care at certain times and even non-compliance, which then for me begs the question, if we could have offered a patient like this a non-invasive way to screen without triggers and without sacrificing accuracy, could we have changed her long-term outcomes? That answer we will never know, but I like to think that an option like self-collection could have created a safer entry point into screening and follow-up for her, one that maybe reduced PTSD triggers, preserved her dignity, and maybe even gave her more control in an experience that impacted her forever. So when I think about the value of self-collection, I think about her, and that is the kind of impact for us that really matters. Ultimately, this is what progress looks like in cervical cancer prevention. When screening becomes more accurate and more humane, we do more than just improve care. We reach more patients, we prevent disease better, and we move closer to eliminating cervical cancer in our lifetime.
Thank you so much, Kylie. That was so amazing to hear from you and your perspective and how you brought on clarity into your clinical practice. And, we hope to see you all again in the future. Thanks so much, everyone.